So, a new study was just published in the Journal of Applied Gerontology that investigated skilled nursing facility care at home for adults discharged from the hospital. So first I was like, whoa, is this going to like replace SNFs? Are SNFs going to close down? They're going to do this SNF at home approach. I know this is a pilot program, but this research could be investigated further and there could be upsides to this that we're not thinking about. And I think there definitely are, reflecting back on some of the benefits from being at home and receiving rehab in such a setting. So what is this study about? Well, typically for patients who are not ready to go home from the hospital and for those who may need more medical care, arguably more complicated medical care and attention, as well as rehabilitation, would go to a skilled nursing facility, a SNF. And this study looked at providing a similar level of care as a skilled nursing facility, but instead of going to a skilled nursing facility, patients do rehab at home instead. I say similar to traditional in air quotes, as you'll see in this study that it's not quite the same as the level of care that patients receive at a SNF. And note that this is different than discharge home with traditional home health therapy after a stay from the hospital. So they're making this different. And a skilled nursing facility, what it does is it provides a higher level of care compared to just going home for patients, because they may need, say, around-the-clock services such as nursing. So are SNFs in danger of closing down then? And should some healthcare providers, such as therapists or nurses or CNAs, fear losing their jobs, especially if they work at a SNF? Well, let's check this study out. If you are new to this channel, my name is Jeff, a board-certified and licensed occupational therapist practicing in America. My goal is to increase awareness about the profession of occupational therapy to help people live healthier and happier lives. If this resonates with you, consider subscribing to this channel and joining to be a member to support my content. Let's get functional. So why are the researchers even exploring a skilled nursing facility at home approach in the first place? Or what they call rehab at home, RAH for short. One point that they make is that SNFs traditionally have variable safety, quality, and patient experiences. Some Medicare patients, for example, experience adverse events that may have been preventable. Some of these events even result in patients returning back to the hospital, which is unfortunate because, the goal is to instead go home and reintegrate and go back to living in your own community. The second they mentioned is cost, and one proposed way, therefore, to save on this is to change how things are paid for, such as the location. So if you're not paying for services at a traditional SNF, which have, you have to turn the lights on and pay for electricity, staffing, taxes, and so on, whereas at home, well, kind of the patient pays for that already themselves. And I would argue that, well, with all these points made, especially safety, that is and should be priority number one, safety, because we want to avoid, especially as healthcare providers, not only avoiding to do harm, but also to improve health outcomes, right? So shifting the rehab site to home, how will they manage things like safety where and they even would argue that it's in terms of safety than a traditional SNF? Well, one way they do this is with technologies and shifting the task from parts of the task from humans to technologies. For example, they use automatic continuous monitoring sensors, which is pretty cool, but I do have some of my concerns about privacy in today's tech space. Some good points that they do make is that at a home environment, it allows for the support and interaction of family, and of course being home would make one more comfortable, at least in theory. My thoughts on this is, well, not every home is a good environment for therapy. So I wonder if these researchers are the people who referred, such as case managers, screened for the home environment and it was a good fit. So this isn't a good fit for everyone. There could be distractions, a dysfunctional family, or even be unsafe physically, such as fall hazards. Or there could be family members who may be a barrier to therapy and recovery. For example, what if they have an alcohol problem or are abusive or even just abusive psychologically? So although there are often psychological benefits to being at home and recovering there, it could also be a barrier depending on each individual's patient circumstance. So this is why for me, for example, in acute care, when I look at discharge planning, I look at each person's situation. I ask them what their home setup is like. Who is there to be a caregiver? What are their finances kind of like? If that is an issue I kind of suspect is an issue, what do they already have in terms of equipment? Or, do they have like a family member who's like a nurse or a therapist, so, or even where they live would dictate what kind of services they may get in terms of like home health. So it was a pilot randomized controlled trial that assigned 10 participants to two groups. One was the RAH group, the experimental group, and a control group. The control group was basically traditional skilled nursing facility care. The participants were adults recruited from a hospital and I think two local hospitals, and they were screened by case management to ensure that the patients would indeed benefit from SNF care. So not just like, oh, anybody, let's enroll them in the study. They're patients who are appropriate for going to a SNF in the traditional sense. And also, I think inpatient physical therapy played a role in referring patients to this program and their appropriateness of going to a SNF or a rehab at home program to split them into the two experimental and control groups. It would have been, I think, nice if occupational therapy, I don't think they were involved at all, and to address things like functional performance and evaluating them for ADLs, IADLs, leisure, sleep, health management, all those things. And conditions for the participants included, say, cardiac, respiratory, orthopedic, and infections. So what was missing was neurology. Patients who were excluded, it's worth noting that those who were on a ventilator, those who required hemodialysis, IV medications, or blood transfusion products were excluded from the study. So this is a good majority, I think, of traditional SNF patients, and this makes me think that the participants were more higher level or they were more stable and needed less medical interventions, at least from the nursing staff, like an RN, like registered nurse. So what was their RAH intervention? The thing I was most interested in, at least. And that's worth considering as they propose it as an alternative or maybe a supplement, but another good alternative, to a traditional SNF setting. So in the RAH groups is what I'll be talking about from this point on, because we all know what traditional SNF is kind of like. Once patients were home, they were assigned to a certified CNA visit and a physician's visit. The CNA was there to visit daily with an RN available as needed for consult. So it's important to note that there's no actual RN on site. The CNA is not there all day either. So I think in terms of cost, this would help to cut down on costs. As in traditional SNF, you would have nurses and CNAs there 24/7, right? So that ups the cost. And how they handled, say, medications was they used an automated assisted remote technology dispensing system that they can program remotely. So that's kind of really cool. I mean, kind of curious this from a nursing standpoint, even though I'm not a nurse. But, medications are part of, our health management occupation. And in terms of the doctor, they were looped in, I think either via phone call or text or like virtual. And who was there, who was present 24/7 was a home health aide, present 24/7. So this covers, I think, from their standpoint, the researchers, the safety part. And it also helps, I think, to cut down on the cost because you don't have, compared to a traditional SNF setting, all those staff on site. What about therapy, right? Well, PT provided their interventions remotely via virtual therapy sessions up to 3 times a day. And home health aides assisted with the therapy, it seems, as the physical therapists were not there physically. And I wonder, since they mentioned ADLs and the outcome measures and IADLs, if the PTs were the ones who were doing these therapies instead of OT, I don't know. You may be wondering, well, what about things like vitals too? Like, how did they monitor it? Because when we mobilize for therapy, we take vitals and stuff to like look for orthostatic hypotension, especially if there's cardiac involvement, right? So they did remote monitoring of vitals for things such as heart rate and respirations. I don't think they mentioned blood pressure, but I'm sure they measured it, hopefully. They even measure something like step count, and I'm not sure how accurate and how calibrated these things are, because in my experience with step count devices, they're not that good. And so with all these gizmos, what comes to mind is data privacy. My concern is, what system do they use? How secure is it? Is this data stored on the cloud somewhere? Who has access to it? How long is it stored there? Do they do updates? Like, what kind of this is all kind of like a black box, and this is all patients' information that, you know, there could be HIPAA violations. So who's looking at it, and ultimately, how much control does the individual patient or their family members have over this data? I think this will be a reoccurring theme with things, as everything is connected to the internet these days, especially medical technologies. And while I do see the intention of it, if these things were to be compromised, there could be a lot of issues as well. So not only safety I value, but also security of devices and how well these are implemented. Because to cut down on costs is one of the points of the study. Like, do they cut down on the costs in the advancement in, you know, proofing of the technology to make sure it's secure? And again, no mention of OT services, which is kind of disappointing, but I do realize this is a pilot study, but these participants could have benefited from a collaborative approach with PT and OT. And what about speech? Maybe they would have been involved, but they go on to measure the ADLs and IADLs. So this implicitly implies the need for OT too, right? So I'm kind of confused here. So what were the results of the study? The RAH group had an increased outcome measure score in ADLs from a score of 2 to 4.5 in the RAH group. In the control group, so traditional SNF, ADLs remained similar from 3 to a small bump to 3.5. So this is not what I expected at all. I expected the SNF group, traditional SNF control group, to have a higher ADL score change, but the RAH group showed an, on average, higher score. So keep in mind that this was only a 10 participant sample size and a pilot study, so this research is not generalizable to broader populations, and this is what the authors also point out. But at the very least, we can see that the RAH group, whatever it really did, is at least as good as, if not better than, SNF in terms of ADL outcome improvement. I am also kind of skeptical that this pilot program produced better results for ADLs than a traditional SNF, but I'm keeping an open mind. Maybe we have been doing it wrong this whole time. Should we be looking at this data and this approach and how we can improve ADLs from being at home? And they also measured IADL changes as well too, and it was from 3 to 3.5 for the RAH group, so small bump. But for, again, we're seeing similarly with the control group, it remained at a 4 for the traditional SNF for IADLs. In terms of health-related quality of life, it remained similar, so no QOL improvements. But they also mentioned that patients slept apparently pretty well, which is no surprise here, being at home. The RAH group, the patients slept in a familiar home environment without unnecessary sounds and stimuli going on, such as from alarms going off all of a sudden, or your neighbors yelling and whatnot. So patient experience was reported to be higher in the RAH group, which is, I think, pretty cool. It's a really nice benefit of being home, and why I advocate for home environment for some neuro patients that I work with, because it's familiar, and for neuro patients, it could be challenging to manage their recovery with all of these aspects. Meanwhile, try to also adapt to these changes that are only temporary at a SNF. I'm also willing to bet that some of the patient experience factors were attributed to say, maybe home-cooked familiar meals and not having, say, your roommate create noise, or even having to share a room with them, or like sometimes at a SNF, like 4 patients at a time in one room, and you have your own private space too. So patient experience, naturally, I think, going to be higher in the RAH group. And another big finding, definitely worth noting these days, is the cost. And the RAH group costs on average about a rounded, I think, $8,400 compared to traditional SNF control group of $9,200. So $8,400, $9,200. And that's one patient. So you multiply that by hundreds, thousands, that's a lot of cost savings, right? So one upside to the RAH group. And Note that the lengths of stay were the same, 14 days, so same amount of stay, higher cost. What was excluded from the cost, I think, were physicians, as they were billed as a separate line item. So physician services were not factored into these two cost comparisons. So in their discussion, the authors state that the RAH pilot compared favorably to traditional SNF with benefits of lower costs, greater functional improvement, and better patient experience. And these are actually the IHI's triple aim points, by the way, that we're trying to achieve as healthcare providers for a better overall healthcare system and experience. The better patient experience, lower costs, and better health outcomes. And there's arguably now they're proposing a fourth point to the triple aim to become the quadruple aim. And one of these proposed factors is improved caregiver, so healthcare provider like me, our experience to help reduce things such as caregiver burnout. So maybe this could help too, because working at a patient's home setting may be less stressful, maybe more fun. I don't know, it depends really on what's your perspective and whether you like or not, say, traveling and doing kind of like a home health kind of gig. And the big conclusion that they kind of draw is that this delivery method, this RAH, could reimagine how we deliver post-acute care, but of course, more research is needed. So, what are my thoughts on this study? Well, first, I was wrong about the costing. Apparently, one of the highest costs for this study that for the personnel was for the home health aide in their hours, and not for other staff such as CNAs and RNs, which makes sense. Even though they're more expensive in terms of like hourly, they weren't there really all that much, and they were only there part of the day. What does cost the most is typically 24/7 around the clock care. So it probably helped with the cost savings there. And from my experience, from a discharge planning perspective, typically, no matter what initial setting you're from, say hospital or acute rehab or SNF, anytime you have to recommend 24/7 around the clock care, especially when hired 24/7 care, it's gonna be very expensive. And not all patients, I would say most patients, like I wouldn't be able to afford the finances for this. So this could be a barrier. So it's easy to recommend, oh yeah, this person's not safe, they have a high fall score, they have poor safety awareness. Yeah, 24/7 care. But can they really afford that? You recommend that, they end up not getting it, and then they end up having a fall because, like, I don't know, like 6 hours of the day, no one's there to watch them. Then that's kind of a recommendation that you make, but it's not a client-centered one. And in those types of cases, you have to, from a discharge planning, work with the team and case management and social work to think outside the box to how you can maintain safety, prevent falls, and prevent hospitalizations to overall cut down on costs on the overall healthcare system. And this is worth noting that this study also relies heavily on the physical presence and availability, though, of home health aides, which could be a problem based on the location, which I also perceive there to be probably a shortage of home health aides, and there could be a lot of variability in training and competency too. I don't know what kind of, I'm not familiar with the home health aide training side of things compared to, say, nursing or physical therapy, occupational therapy, doctors and techs and that kind of thing. So if you guys know in the comments, let me know like what kind of training and what kind of competencies home health aides are needed, because the RAH group is argued to have better safety as an alternative to SNFs, where you have CNAs and nurses on staff 24/7. So I would imagine also too that some of the interventions are not there, or not done then. So like skin checks for like decubus ulcers or dressing changes, they mentioned no IVs are needed, but there are other things. So maybe these patients are higher level too. And a big portion of the SNF population and residents do have these needs. They're not as easy to mobilize. So it sounds to me that this somewhat is high level for PT and OT needs. Does PT and OT, what is their involvement for some of their ADLs and IDLs? Again, the participants experience more straightforward conditions. They mentioned like pneumonia, fractures, and infections, not things like stroke or TBIs where I'm more used to seeing. And they require more intensive therapies, such as to mobilize out of bed for transfers for ADLs and IDLs. But the more that I think about it, this study sounds and seems more like, well, a more organized kind of home health program with things like sensors, assistive technology like medication dispensers, and telehealth. I wouldn't technically call it myself personally a SNF at home, so to say, as participants are also relatively stable medically, and their therapy needs, although not explicitly mentioned, were achievable basically over telehealth. And again, no OT was mentioned, so I'm not quite sure, although I would have liked to seen this and see how it would have probably improved the ADL scores. It probably would have improved it, who knows, like fivefold for all we know. So I think follow-up studies should include OTs in it to see if there's a change. Would alternatives be better than even this RAH approach? Like, have they compared it, maybe say a shorter SNF stay and then home health transitioning there, or something else entirely? So what are your thoughts on this, especially students who have done fieldwork at a SNF, or OTs who are currently working at a SNF or have experience working at a SNF? What are the pros and cons for this type of RAH rehab at home program? Let me know in the comments.